Hello, everyone. Good morning still. Everyone can settle in. Everyone has a drink. Great. Okay. Yes, so welcome to our second international panel. Just for everyone as an information, this is the first time the BGW is actually having international panels. So we're very excited to run this as a pilot study and to have a very diverse and international panel here with us today. I just want to introduce myself. My name is Miriam Stuckert. I'm with the BGW, and I'm also representing the ISA today, which is the International Social Security Association. So this is also all hosted by the ISA and in cooperation with people who are working with us in that regard. And what we're going to be talking about today is the big topic of actual resilience of the hospital system. So I think everyone knows by now the COVID pandemic has been quoted by many as one of the biggest health crises since the Spanish flu. And it has hit the hospital systems all over the world very hard. So we want to take a step back now, seeing that we've gone through the worst so far with COVID, and we want to see, have we learned something? Hopefully, yes. And also, what have we learned to protect our staff and the people who are actually working in the hospitals? So we have 4 experts here who have traveled from literally all over the globe. So thanks everyone for making the journey. Very glad to have you here. And they're going to give us an insight about what their organizations are working on in that regard. And we're going to start with you, Daniel. Thanks again for being here, for joining us. And Dr. Daniel Opoku has come from Ghana yesterday, so I think you might be the longest journey. Maybe you're tired with New York. So thanks for making a long journey. And he's a lecturer at the School of Public Health at the University of Science and Technology in Kumasi, Ghana, and has a lot of research experience, specifically with health system and policies, and has a very strong interest and background in technology-based health services. And he's continuously involved with kind of German and Ghanaian projects, so he will hold his talk in German, in English today, but he's also capable of German, so if you do have a German question, don't hesitate to ask him as well. So, for example, he's involved in a research project focused on e-health, so again, the digital component is coming in there, and it's actually funded by the German Federal Ministry of Education and Research. So it's, again, a German-Ghanaian project, and he's also involved with the German West African Center for Global Health and Pandemic Prevention. And this as a keyword for our session now. Daniel, stage is yours.
Thank you very much. Thank you very much for having me. It's a great pleasure to be here. It feels like home, Hamburg, anytime I'm here, but mainly based in Berlin, as Miriam had already introduced me. Thanks for your kind introduction. Today I'm going to share some insight or reflections that, together with my team, and other research collaborators have been thinking about on the incentive packages for COVID-19 frontline health workers in Ghana during the heat of the pandemic, and what the effects were and whether they are lessons for policy in the build-up of our primary healthcare system, or building health systems towards resilience in this case. In the next 15 to 20 minutes, the outline will focus on a humble reflection on COVID-19 as the big leveler for all countries of the world. And then we look at some of the critical efforts that most countries, particularly those that were vulnerable, and international forecasters projected and estimated that some African countries were even going to be extinguished based on the COVID-19 pandemic because of the wave, and looking at it from the fact that the COVID was a new learning for everybody, or learning experience for everybody. And then look at particularly the incentive package system, the way Ghana's experience is, how we motivated healthcare workers to take up the fight against COVID during the pandemic. And then look at some of the effects and then conclude with the lesson for policy. It's quite clear 3 years down the line that COVID is estimated to have killed almost 7 million people worldwide. This is a hard hit to many countries, including the United States, Russia, Mexico, UK, Spain, South Africa, and others. Unlike Ebola, COVID posed equal risk to every country, and every country was seeking the same remedy. It was also for most of these countries, we did not know, or we really had little knowledge about COVID. And there was also serious blunders that were caused. Think about China's hard lockdown policies affecting economic growth. Think about UK free for all, where they wanted to aim for herd immunity, and that caused serious ramifications for them. Serious blunders. For example, the premature celebration in Brazil and the likes. But in all these, what were some of the measures that most countries were advancing on? Apart from the quest for vaccine, there were also the non-pharmaceutical interventions, the wearing of masks, the adaptation of closure measures for schools and economic activities, the banning of public gathering, like we could not have held this conference in person here 2 years ago, and restriction on both international and domestic movements. Businesses were shut down. All these activities were measures that were being taken. Let's look at the pharmaceutical side. When they announced vaccines or the discovery of vaccines, the priority in terms of the group or the population that was at risk was mainly the healthcare workers, because they were supposed to be at the fight, at the front of the fight, and therefore were the most at risk or exposed. And so all the projections from various countries prioritize healthcare workers. But we notice that, of course, not all countries met their vaccination targets. And so when vaccination targets fell short, most countries adopted 2 levels of interventions. One will be restricting movement for non-vaccinated people, and you think of Israel's green pass, and then for those who are vaccinated, and you think of the Germany's 2G, 3G restrictions. Most of these countries did that. In Uganda, they needed even to have the police, an armed police, to enforce even the restriction of non-vaccinated people's movement. But there were vaccination hesitants. And these vaccination hesitants were caused based on the reasons associated with the limited information about the vaccine safety and its side effects, as were also evolving. And one important thing, the lack of trust for the pharma industry. And then also the misinformation and conflicting information that were being churned out there. Vaccine acceptance within the sub-Saharan region span from some 7% to about 98% across over 30 countries that this review had surveyed, including Ghana, etc. Zooming into Ghana on what Ghana really did. Ghana first became the first recipient of vaccine shipment using the COVAX instrument. This was a major intervention for Ghana. At the time, countries all over the world were also seeking similar needs. But the receiving or reception of vaccine did not necessarily result in 100% vaccination. And so when we had done this vaccine acceptance or hesitancy survey, we noticed that not everybody was being vaccinated. Two major variables play out here, that men were, or the male gender, were more likely to take vaccines, and those who were educated or high-level education would have taken the vaccination because they recorded a higher scores. And this reflected the previous slides I showed on sub-Saharan African regional levels survey. But what really went into Ghana's perhaps seemingly successful way of handling COVID? We roll back to before COVID, the pre-pandemic, and Ghana had then taken some measures as if it knew clearly that COVID was really knocking at the door. One of such measures was the purchasing of ambulances for all the constituencies in Ghana. Over 260 constituencies in Ghana. They had purchased ambulances from, of course, Germany, Mercedes, to do this exercise. And that was very instrumental during COVID. Another measure was also building more hospitals. There was a declaration by the government to build 111 district hospitals at the apex hospitals for the primary health care. And this was going into strengthening the primary health care services. Then there was also the growth of training facilities for healthcare professionals, which Ghana recorded. For the past 2 years, Ghana had produced over 32,000 cadres of healthcare workforce from the training institutions. Another interesting thing was also the scientific capacity that it had injected in building, for example, the KNUST's, there's a collaborative institute with Bernard Nock Institute here, which goes, I think it's past 25 years as existing in their collaboration, called the KCCR, the Kumasi Collaborating Center for Tropical Medicine Research. And then also, you have the DIMS data, which is the District Health Information Management Systems, that was in place. And because of reliable data from the DIMS, this actually underpinned Ghana becoming one of the first countries to receive the COVAX vaccine. Another instrument which is Ghana is very proud of, is the use of drone technology to deliver essential medical commodities, particularly to the remotest areas. I think of blood. instead of transporting the human or the patient to the regional facility or the tertiary facility, they would rather have the regular supply of these essential commodity to be taken care of. So this is a massive, and Ghana, by the way, is the first country to use drone technology in the world for the supply of medical goods or commodities, called the zipline drone technology. So these are the pre-pandemic, I would say, levers that really help or inured to the Ghana's able to handle the pandemic. Now, during pandemic also, some of the measures and mechanisms that Ghana had then taken, including the airport restriction, which all countries were doing, collaborating with research institutions, and also collaborating with the private sector, building up COVID-19 task force, and also setting up isolation center, which took inspiration from Ebola, because then there was an Ebola Ebola center that was built in Ghana, which was helping the three countries, Liberia, Guinea, Sierra Leone, who were hit by Ebola during the time. And Ghana then sent healthcare workers to help with that. But one profound measure was also the tax exemption or the incentive package for healthcare workers, where Ghana had highly adaptive healthcare community that in the country, particularly with the community health workers. When we say adaptive healthcare community, the building of community health workers as part of their routine healthcare activities will be childhood immunization. So when they had to go to houses to vaccinate people or go to the community to vaccinate people, these were already existing skills that they had acquired. And mainly the incentive package that I am going to throw more light on. What was this incentive package? In fact, one highlight was also the risk communication that the president himself took opportunity to deliver most of the measures that were put in place during COVID. This showed a highest political commitment, and most countries were, of course, also doing that. On my count, Ghana's president addressed the country 29 times during the COVID, and the last one was held in May. But the fifth address was when the government had then declared the incentive package for the healthcare workers. What was this incentive package? It had given them a daily allowance of some 150 cedis, approximately 26 now. By the strength of the cedi, this will be reduced to some $15 payable to those undertaking the contact tracing. Another incentive was the exemption from the payment of taxes on their salaries, and this took effect for 3 months from April. Then you have additional allowance of 50% increment on their basic salaries per month for 4 months. That was also given. And the last one was an insurance package which assured most of the healthcare workers to a tune of about $60,000 during the COVID pandemic period. The question then was, were these enough monetary incentives enough? Does it assure the security? Does it assure a safety net for healthcare professionals? So we took to, as a research organization, we took to the field to survey and interview healthcare workers. On the one hand, about their contribution to the COVID, and on the other hand, to look at really what are their motivation. Is it the monetary, or what are their motivation? What gives them the sense of security for the work that they do? Profoundly, we found that it said teamwork and mutual support from colleagues was a key approach for building resilience towards stressful work demands among the healthcare workers. And the sense of identity within the response team and the shared common goal, which their goal was that a sense of responsibility, that they need to do something to serve the country, drive also their motivation to work. What were the effects of these? The highlight is there is a sense of responsibility and altruistic devotion among healthcare workers. And a profound quote from them is that, it just felt like that's what they've chosen to do. So no matter what, you have to fight because you have to save your country. Yes, and you are there to help your country in times like this. And talking about the fact that they are involved in the childhood immunization, a practice, so it wasn't really a big challenge for them to adapt to serving COVID-19. But this does not prevent us from highlighting some of the critical challenges that healthcare workers faced, especially during the COVID. One was the exposure to this traumatic event, and this being also the highly at risk and contracting COVID and its associated stigma and social exclusion that came to their families and the communities not even accepting some of them. The burden of new responsibility with its accompanied prolonged working hours. And one thing that healthcare workers, even though they were used to, but not for that long, wearing nose and face masks throughout, not just at the clinic or the health facilities, but also when they are going home in their own communities. This became a bit unbearable also for them. And then the lack of adequate resources, which is very well known phenomenon. Then the cost of living, which also came about with it, that healthcare workers were not necessarily excluded from the hardship, the economic, financial hardship that COVID brought, and they also spoke about it. Now, what are the lessons? And I am tempted, it's a favorite quote from one of, potentially considered or widely considered the first existentialist, Soren. And he has this famous quote that life can only be understood backwards, but it must be lived forward. So my conclusion was that in order to enhance the motivation and the performance of healthcare workers, especially for the strengthening of primary healthcare systems, the COVID-19 relevant policies should be adapted to reaffirm the steps that have served all of us well. That we do not need to wait for a pandemic before we are ensuring our healthcare workers. We do not need to wait for a pandemic to increase their salaries 50%. We do not need to wait for a pandemic to supply them the needed resources that they need. Thank you for your attention.
Okay, thank you so much, Daniel. That was super interesting, especially I think Germany can learn a lot from especially the digital approaches, drones delivering medication. You said it's the first in the world, but I think in Germany that is very much unheard of. So here's to hoping that that is also our future. We would structure this. So if anyone has questions for Daniel now, you can post those questions. You can also ask them in German if you feel more comfortable with that. I can translate them as well, that's no problem. Or we can also take questions at the end. But maybe now, as it's still fresh in everyone's minds, if someone does have a question, feel free to pose it now. Okay, there's one question over there.
Hi, Daniel. Thanks for the insights. My question is how is the health system in Ghana structured? Is it a central plant or is it decentralized? Because I think we saw in Germany lots of fractions between the different political levels, the different countries in Germany and so on. So if you could give us insight into that.
Thank you very much for the question. So Ghana's healthcare system will rather be assumed to have been decentralized, i.e. you have the Ghana Health Service as an establishment by an act of parliament responsible for the primary and secondary care level. And their mandate is therefore to ensure healthcare services or delivery at the doorstep of the people. So the structure of the primary healthcare has 3 levels. We have the community level, i.e. the local, which deals with the Ghana's model of community health or community-based health planning and services called the CHIPS, where communities are earmarked into compounds. And you have the healthcare, community healthcare workers who live within the communities that they serve. So the first community itself build facility for them, and they live within the communities that they serve. And that's at the very base of the healthcare structure. Then you have the health centers, which is at the sub-district level, called manned by a physician assistant. But of course, there are places where you may get a midwife who is also posted there. And the focus within these 2 levels of healthcare is on maternal and child healthcare, and then health promotion and health prevention. So what they do is that you have community health workers who visit households with children under 5, where they visit the mothers on a regular basis to check and take vital signs and things like that. And upon when they see any signal of a danger sign, then they report to the district hospital. Some places have the teleconsultation or telemedicine centers, others don't. But where they do have the operations of telemedicine, then they will respond or connect through the telemedicine to the district hospital. And then you have the district hospitals. So all district hospitals are supposed to be the referral points for the 2 lower levels of facilities in that case. And the district hospitals will have some levels of physicians, specialists, units, etc. But it's not as big as the secondary level hospital. And then you have the secondary level, which is then at the regional level facilities. So Ghana currently has 16 regions, and then the goal is that we have 16 regional referral facilities. And then the apex of the healthcare system, which will be the tertiary or the teaching hospitals, and that Ghana has currently 5 of them, strategically positioned to cover some geographic location. So the one in Kumasi, which is the Komfo-Anokye Teaching Hospital, will cover both the northern belt and then the middle belt. And then the Kolebu Teaching Hospital in Accra will cover the southern belt. So this is how decentralized the healthcare system in Ghana is.
Okay, thank you so much. Seeing that we've progressed a bit in time, if there are any more questions, we can see if we have time at the end. Also, maybe if we have some online questions, we'll check in later and see if we have some more time. But thank you so much for the question. Okay, moving on to you, Gareth. Thank you so much for being here as well. Gareth is originally from Ireland, but he's been in the UK for quite a few years now, and he's involved in healthcare for nearly 25 years as well. So a lot of expertise here today, and he started his journey with a BA in public management for healthcare, and is now the founder and CEO of the World Health Innovation Summit. So it's a great program that you will share with us today, and especially the Global Social Prescribing Alliance, which I'm very excited about. He's also very busy being an advisor internationally. So he's helping out with the Great Green Wall of Africa Foundation with his expertise, but also with the Good Economy, which is an investment advisory firm. And he was also part of Pope Francis' commission during the COVID times. So very happy to have you here, looking forward to your contribution.
Thanks very much. It's a pleasure to join you, but I think the last question is very relevant to this discussion. Healthcare is definitely political. Daniel gave an example there of the complexity of arranging healthcare systems. And I think if we look at COVID and we look at the future and the lessons that we've learned, we have to accept that health is emotive. So it plays on politicians' minds. And you make a lot of decisions are made kind of reactively. So not necessarily in the best interest going forward. I'm going to talk about the future of healthcare, lessons learned, looking back, reflecting on COVID-19 and future pandemics that are around the corner. And then from a health perspective of our staff and well-being, what is the impact and where are we actually at this current position in time? How do we prepare our health services for the future? Just to give a context, in terms of the problems that we face a shortage of 18 million staff by 2030. I mean, these numbers are just astronomical. Currently in Germany, I'm sure you're aware, there's hundreds of thousands of vacancies in health and social care. It's the same in the UK. We face serious problems. NHS England, for example, about 100,000 vacancies. Daniel will be aware by 2030 there'll be 6 million jobs vacant in Africa around health and social care. There's a problem there in terms of investment as well, because how can you drive in investment when you don't have a workforce? This is some of the conversations I've been having with some of the large pharmaceutical companies in terms of developing new models of care in Africa. It's a significant problem. Just can I get my presentation to go forward? It says just clicker.
Did you turn it?
Just share. Oh.
There you go.
Okay, sorry. Okay, so I just wanted to give the context here around the UK. Long-term sick leave, there's a huge problem in the UK. So I'm going to focus as well on the future and moving the system from disease management to healthcare in the future. The UK at the moment, there's about 2.5 million people out sick leave. And the impact on the economy is about 150 billion. It's a huge drain on our economic resources. Health is wealth. We've seen with the pandemic, once people are unfit and well, they can't have a job, they don't go to work. Okay, this is an enormous impact on our economy. What we need to understand is, as we move forward, that health is wealth and that the economy is driven by people being fit and well. This is part of our work. 2018, I gave a talk about preparing for One Health, shall we say, pre-pandemic, and the reality is we're not prepared. Lessons from COVID, are we ready for the next pandemic? That's the question. Would we react differently? I would say that we're in a more precarious position. We've lost a significant number of healthcare professionals. We face huge challenges as we move forward in terms of pressure on the system. Enormous challenges, rising population, ageing population. These are all putting enormous pressure on the health system. If we look at what happened to our health system and our hospitals during COVID, effectively they grind to a halt. And this resulted in about 28 million elective surgeries delayed worldwide. In the UK at the moment, it's about 7 million people waiting for elective surgeries. Now, the problem here is if you're waiting for an elective surgery, it's fine if you're waiting a couple of months. But if you're waiting 24 months or 36 months, effectively you will soon die. This is what we're seeing in the UK. So you're seeing huge spikes in mortality rates. So the actions that we took during COVID now have a real impact and long-term impact on our health and well-being, not only in the hospital system, but the wider economic impact as well. As I mentioned, over 115,000 medical healthcare professionals have lost their lives. Daniel talked about the incentives for medical workers to go in. I mean, you'd be frightened to go into work if you think you're going to contract the disease. You know? So these are huge problems for the health service, and the trauma, as Daniel's mentioned, has a wide effect in terms of recruiting and retention of new staff. I just want to talk about the existing problems that we have and what comes in the future. And this again, I just want to emphasize the pressure that will be put on the health service, because it's important that we have these conversations. You know, Alzheimer's, dementia will rise from 50 million to 152 million. I mean, in the US, for example, you know, it's nearly $1 trillion they're spending on dementia care at the moment. So these are huge problems that we need to be aware of, but it's also an opportunity. This is job creation opportunity here. Climate and health is a huge factor. I'm doing some work with the Great Green Wall of Africa across the Seychelles, and I think this is again an area where we can address climate change and health at the same time. So with all this investment flowing into climate, we can divert some of that capital into health. Air pollution, for example, kills millions of people a year. The link between health and climate change is intrinsic. So we need to make this link. It's very important with COP28 coming up that we make this link and we make the business case, while all this investment is flowing into, you know, new energy resources, that there's a link made to health and well-being. It's very important we have a holistic approach here. You know, air pollution, I just mentioned it there. You know, look at the economic costs for air pollution. You know, $2.9 trillion. I mean, this is an incredible amount of money. £8 billion dollars a day that it costs in health and well-being. If you look at respiratory diseases, they're rising. All these are due down to fossil fuels. One of the things we need to be aware of is the contaminants of emerging concern, and this is all through our food chain, pesticides that we're using. Again, this puts more pressure on the health system. And one of the most important things is actually the fertility rates are dropping as a result of this. So we need to be aware of this as we move forward, because when we look at the 2030 agenda, or 2050 or 2060, there won't be a 2060 if we don't get this right now. So it's really important we take action now. When we talk about mental health and well-being, I wanted to touch on this because this is significant, particularly in the area and the age that we live in with social media and so on. I just wanted to show this as an example because when we have children looking after their health and well-being, there is reasons behind this. You know, we need to understand that the first 3 years of life are critical, and that supporting women and children as they grow up is vital to the future of health services. We need to shift our model from managing disease, people getting sick, coming to hospital, we look after them. No, we need to take that back downstream and support families earlier. £1 invested, we get 36 back. That's the model we created in the UK based on early intervention. There's a huge opportunity, as I mentioned here. This is some of the lessons from COVID. Better health equals improved economy. This is, we have a huge value proposition. You can tap into human capital, build trust with communities. The biggest lesson from COVID, what did we do well? We went out and we met the public. We implemented the vaccine program, which worked well. Let's not redress. Let's go out and meet the public. That's where the opportunity is in the community, and then consolidate our health services, bring in, because as I said, lack of resources, centres of excellence. This is a massive opportunity. The area that I'm completely focused on at the moment is on the right-hand side. The left-hand side is current legacy system, which is basically managing disease. The opportunity is on the right-hand side, where we can develop the likes of social prescribing and new programs in the community. This is about job creation as well. And, economies are changing. We have disruption through artificial intelligence. Governments are looking for new ways to create jobs. And this is a new way of creating new jobs. And you can also anchor this into an existing healthcare system, which is worth about $12 trillion. So think about the opportunity cost. I just gave the example of £1 invested, 36 back, okay? So your opportunity cost is 1 by 36 by 12 trillion. This is how you create new jobs. That's the opportunity on the right-hand side. An example of what we've been doing in the UK is these sort of community health melas, where you bring in the stakeholders, which are your patients, you engage them at the coalface, and then you create an economic model where you're actually promoting public health and well-being. This is what we've been pioneering in the UK, but we want to scale this globally through our Global Social Prescribing Alliance. I just wanted to give people an understanding of the wider economic value here in terms of investments, because I think one of the questions that we have to ask is, what is the link between healthcare and financing? The question what popped into my head when I was working for the government in the Irish healthcare system, like, where does my pension fund go? What is it invested in? And you'll find it's invested in tobacco or it's invested in oil. This makes no sense. So this is an opportunity for the health sector to actually divert resources into community good and invest in new ways of healthcare. These are serious questions we have to ask. Our model is around preventative healthcare, and this is sort of the system that we've been deploying within communities in the UK to promote health and well-being at an early age, so starting in schools, then in the workplace, and then also across energy, waste and water. Digital health will play a huge role in the future of healthcare, a massive opportunity. It's a hard one to crack, but if you can alleviate pressure on the health system, you can build a business model around it. Africa has very little legacy. There's a huge opportunity in Africa in terms of digital health, particularly with the lack of resources and manpower. So these are the sort of areas that we're focusing on from a digital health perspective. I'll skip through this because I think this is probably an old presentation actually. These are, but the Global Social Prescribing Alliance. So we set up a social prescribing alliance. I'm not sure if people in Germany are familiar with social prescribing, but this is effectively a link worker who works with a GP, and you're referred to the link worker for mental health and well-being issues, and then you can be referred out to the community. This takes a lot of pressure off the health system. UK has invested about 450 million into this service, and they've delivered about 3,500 link workers across the UK. We're developing this model with the likes of Japan, Australia, Austria, various different countries that are joining the alliance. Our main objective is to spread best practice, to encourage new models of healthcare, and to demonstrate the economic value. So the ROI at the moment that we've demonstrated from social prescribing is about £1 in, £3 back, which isn't a lot, but we are currently looking at how we expand that. So that's the alliance's work. You can see here we have our partners around the world. It's quite an extensive group, very active, and it's also, a huge opportunity for job creation. As I mentioned, the link workers. So in each country, these are new jobs, effectively, that are looking to alleviate pressure on the health service. We're also looking at a creative economy. This is again a new area in terms of the arts. How do you alleviate pressure? For example, if you have 100,000 vacancies in the NHS, how can you move the money from the Treasury from those vacant jobs, which is recurring money, into new money that goes to the likes of the arts? So artists who can support dementia care, for example, in care homes. These are all new ways of thinking. The place-based impact investment is a new way of working that we're working with local authorities, hospitals, and basically coming together and looking at what is the investment opportunity here. So, and how do you bring capital partners, investors to the table so that there's an informed decision. So you don't just build a hospital when you don't have any staff. So these are the sort of things that we need to look at. And as Mark says from the good economy, if we get health right, everything else will follow. That, in a nutshell, is the future of economic, social and environmental policy. Nothing complicated, just plain old common sense. It's about one big organising idea, setting priorities and following through. I mean, that's from the good economy. That's sort of like the new models of care that we're developing across ICBs in the UK. So working with local hospitals, finding out what their needs are, and then bringing roundtables with investors. This is just on the COP. I'll just flick through this because this is a huge opportunity, as I mentioned. Being able to align climate and health, that's our plans for COP. We're working with the likes of Vanuatu to look at, because they're smaller island states who need transition. They can actually make change quite quickly. And this leadership will be key. This is where it all falls down or stands up. We need leaders, and we need to actually promote good leadership. My final slide is just around like what we face. You know, let's stay focused on the future. Let's look at the opportunities, which I said there are. There's plenty of opportunities out there, but we have to take them, and we have to look at new ways of working and shift our mindset. This is just the final slide, and thanks very much, and I hope that was insightful and gives an insight into the future of healthcare. Thank you.
Thank you so much, Gareth. That was great. Thank you for that insight. And maybe if we have time for just one quick question, maybe you're going to have a look at the audience first, if someone's there. If not, we can also have a look at online. Yeah.
Me again.
Yeah.
Could you elaborate a little bit on the link worker? So how does it work with the social prescription model?
Sure. So currently at the moment, when you go to a GP, you get 10 minutes. That's your slot in the UK. You get 10 minutes and you're out the door. The GP refers you to the link worker, and he'll spend an hour with you. And then we'll have a follow-up consultation. And then we'll refer you out to social services, so the likes of men's in sheds, mental health kind of activities. So you're kind of signposting and referring them. So that's how the link worker works.
Okay, great, thank you. Maybe one quick one from the online participation. Do we have anything regarding Gareth's contribution?
Yes. Do you see the Brexit influencing the conditions in the health system as well?
Could you repeat that?
Was it Brexit, sorry?
Yes, the Brexit.
Oh, I think if you see any involvement from Brexit, like does it have any repercussions as well for you?
So from a European perspective, it's probably quite good. From a UK perspective, it's been negative because the reality is good staff. So I know, for example, cancer centres in the UK who would have professors from Holland. Some of these professors have left. So they've gone back to, I mean, when you lose 40 years experience from a department, this is, you know, I mean, it costs lives. So I think we have to be, the impacts of these decisions have far, you know, and in terms of research and development, you know, you disrupt a lot of these processes and it costs money. Ultimately, it costs lives.
Yeah. Okay, thank you so much for that. All right, on to our next contribution, Acran. So nice for you to be here as well. Again, a very long journey. He's come from New York, and he is a physician trained in occupational medicine in Venezuela originally, his home country. And he has a degree in ergonomics and biomechanics from NYU, New York University. And since the beginning of his career, he's really focused on promoting occupational health and safety, especially for vulnerable working populations. So maybe migrant workers or formal workers, especially in Latin America. And he's been affiliated with the NYU Grossman School of Medicine since 2016. And he's working at the Bellevue Occupational Environmental Medicine Clinic and just finished a postdoctoral scholar program. So congratulations on that. And the floor is yours. Thank you so much.
Well, thank you very much for the invitation. Thank you, Miriam. Thank you, everybody, for the invitation. So my role here is to share with you a little bit of the experience that we had during the pandemic when it comes to safe decedent patient handling. As we know, the world went through a mass fatality event, and there is a lot of there's a lot of evidence and scientific best practices on safe patient handling, but just very little on safe decedent patient handling. And so I declared no conflict of interest. At the beginning, we started a participatory ergonomic program on the New York City Health and Hospital System because we had approximately 800 people dying every single day in the city at the beginning of the pandemic. And you know, the New York City Health and Hospital System is the largest system in the United States. 11 hospitals, 25 ambulatory care, 1.4 million patients a year. So it's very large. So of course, it was a huge burden for the system. We were not prepared. No one was prepared in the world. But New York City was the epicenter of at least in the US. And so we started a participatory intervention program to prevent musculoskeletal diseases on these workers who were handling these mass amounts of bodies that all of a sudden started coming into the mortuary facilities within the hospital systems. And not only the amount of bodies that were coming in, unfortunately, but also at the beginning of the wave, most of these patients that were expiring were overweight, 300, 400, 500 pounds, 300, 200 kilos. The more overweight patients were dying first. So that also added not only the amount, but also the type of weight and body that we were handling. That got a lot of traction. As as a council member for the CDC Musculoskeletal Health Council, NORA group, which stages the research agenda for the next decade, it was adopted for the council to actually create a national guideline that will soon be published later this year or early next year publicly for the world to explore on the NIOSH website. The CDC NIOSH is going to be able to share with everybody. So we started looking at the numbers. Like I said, in some places, 800 to 1,000 bodies people were dying at the beginning of the pandemic, and it really correlated with the number of musculoskeletal injuries and diseases that we were having around these facilities. So, of course, it was a problem. We were not prepared, and we said, we need to do something. There was no space, so we started to do interventions to accommodate, of course, the amounts of people expiring, but also accommodate in a preventive way how can we best treat our workers towards this issue that we were facing. A little bit of risk of musculoskeletal diseases. As we know, when we talk about musculoskeletal diseases and injuries, it's a combination of personal, psychosocial, and physical demands, and it all englobes the work environment. And when we talk about musculoskeletal diseases and injuries, in safe decedent patient handling, safe patient handling, pushing, pulling, repetitive motion, you name it, you first think about the physical part, the physical exposure. But the fact of the matter is that a lot of the evidence is growing every day that the psychosocial and stress factors impact has a huge role in the musculoskeletal disease. I mean, there's a lot of theories, high cortisol levels. It's on the evidence. So, of course, we were not only handling a lot of patients, we were not only handling heavy patients, but we were also under huge amount of stress. Not because we were understaffed, because of the amount of patients we were trying to handle, but also because we were living through a pandemic and we were also being victims and the so-called heroes, that we wanted to, there was a big saying in New York, say, I don't want to be a hero, I want to go home safe to my family. So it was this whole confluence of things that were happening that actually made things a lot worse and exacerbated the probability of having a WMSD. Conceptual mechanism, I'm not going to stay too long here. A lot of us have seen this conceptual diagram, but the important thing here is that the organizational factors were affecting the person because we didn't have enough staff. Facilities were not accommodated to help all these bodies, and at the same time, we had the outcomes were basically chronic pain and musculoskeletal injuries with all these patients. So there's a lot out there on handling patients, but the fact of the matter is that a decedent patient is a patient that does not collaborate, obviously, There's also a psychosocial impact with the fact that the person is not alive. And also there is the other psychosocial impact when it comes to the respect for the body, religiously or just the respect in general, to safe handling these patients. So we started to, as a council, more than 25 professionals around the country got together and started looking at this in detail and said, hey, listen, what are we going to do for the next mass fatality event? It doesn't have to be a pandemic. It's a mass fatality event. So are we prepared? Can we be prepared? So we set up a best practices guideline that is going to be shared with everybody. So there are some differences. PPE and body bags affect, when you use a body bag, it doesn't have handles. How do you move the body bag? The environment, the conditions, the space constraint, lighting, task frequency. If the patient does not collaborate, you might say, well, yeah, but we have quadriplegic patients also that do not collaborate. Yeah, but they can communicate with you, and they can say at least, we can work together at least verbally in some cases. But in this case, obviously, it's not the situation. So we looked at stuff like lateral transferring. How can we do best practices when it comes to lateral transferring, craniocaudal J transfer? How are we rolling these patients? Are we rolling, repositioning? We're maintaining position. We're pushing, pulling, inclining, declining. So all these things were studied, were looked at step by step, and to understand what the workers were doing from the point that the patient is expiring to the point where the patient was going to a body collection point that we had to have. A body collection point is basically a container, a refrigerated container outside of the hospital and I'm going to show it, that people were stacked up, unfortunately, in the best way possible because of the mass fatality. So are we hiring? Are we lowering the list? How are we transferring these patients that are not collaborating? So these are things that might seem obvious, but when you're in a situation where you have 800 people dying every day and maybe 50 in each hospital, and it does become a problem. So the main issue is the body collection points. We were storing the bodies outside of the hospital, and they were containers. They were, unfortunately. So how do we push these patients in there? Do we lift them? Do we? No, this has never happened before, and we had to do it. So we had to get creative. There was a lot of great initiatives around the city and the country, and we basically collected the best practices that we had among all the experts, and then we put it on a guideline. Basically, what we try to do is, and I apologize, I should have a slide saying that, adverting people that we were going to see deceased bodies, but yeah, this is a reality. We all live this. I'm not sure if you're in Hamburg, when most big cities in the world had these collection, BCPs, collection points outside of the hospitals because it just didn't fit in the facilities of the hospital. So what we did was, create a handler position where we understood what was the best way to handle these patients that were not collaborating. So we factor in dimension, design, height of the transfer, number of handlers, manual versus mechanical lifting, depending on the budget that the hospital has, how much intervention can you implement, and also what were the best practices depending on what you have as a resource in your hospital. Do you have a center zipper bag? Do you have an envelope zipper bag? So all these things were looked at and put it into recommendations. One of the biggest contributions of the guidelines that are going to come out it's basically understanding what is in general the step-by-step from the moment that the patient expires to the moment that the patient is released from the hospital. And this is basically a non-mass fatality event flowchart But then when you add a mass fatality event flowchart, then you have the body collection point in red. So now we have what we call the containers, refrigerated containers. So, and then we studied all the biomechanical exposures for step by step that a worker goes through that does put him or her in risk of a musculoskeletal disease, including getting into the body collection point. So of course, we used the best practices hierarchy of control. This is the NIOSH one, but I'm sure Germany has, of course, something similar, if not the same. What we always try to do is eliminate the risk, but sometimes it's not possible. So we try to substitute, do engineering controls, administrative controls, and believe it or not, the least relevant is actually PPEs, which is unfortunately what we all focus on. So yes, we have to have PPEs, but the fact of the matter is that in order to do prevention and sustain prevention and create preventive culture is to understand the process from A to Z, so you can at least try to do elimination or substitution and try to do best practices and create and modify and improve jobs. Like we were talking earlier, you know, it's always for politicians, it's important to create jobs, but because, you know, politicians and you know, numbers is what matters. But are we creating safe jobs? Are we creating quality jobs? Are people going back after they rehab and they improve their occupational disease or injuries? Are they going back to the same place they got injured? Or they're going back to a place that is modified in a way that can actually prevent them from getting injured again? So these are the questions that we've been asking for decades, but the pandemic put it front and center. Now occupational health, unfortunately and ironically, is more relevant than ever after the pandemic. So yeah, so these I'm not going to spend much time in these pictures. They're going to be part of the guideline or the best practices. But you know, depending on how much budget you have in your system, if you're a small rural hospital, you might not have a lot of budget, but there are also best practices that we are creating for everyone to use, and we looked at them. You know, how are you transferring the patients? How many people you have transferring, pulling versus pushing? This is ergonomics 101, but we just put it in place in a mass fatality situation. You know, are we storing them in lifts? Do we have floor lifts? We have ceiling lifts. But the most critical point is the body collection point, because it's only used when you have more people dying than you are able to accommodate. So that's where the real contribution comes. How do you transfer these patients? Are you transferring in EMS stretchers? Do you have a scissor lift? In fact, you know, we also have recommendations as, you know, best, next to best, and the least thing that you should do, and we looked at all these exposures and recommendations for that. And you know, and we also went very detailed when it comes to the angle of incline, because you know, you're also trying to go inside a BCP, but you don't want to make it too inclined in a way that the actual pushing will also be hurting the patient. So you know, so it's kind of like a win-win situation. You have a threshold. Do you manual patient handle, or do you push? How much are you pushing? So all these things we looked at, and just like everything in occupational medicine, occupational health, you try to minimize the risk as much as possible. So you know, so there were some suggestions, models. We only looked at experiences within the U.S., but there were other great interventions in Europe and in Asia, and actually China had great also initiatives. But you know, we worked with the resources we had, and you know, it's going to be this is one of the health systems of one of my colleagues that they implemented. I actually think it was pretty good, and when it comes to how you facilitate the going into the BCP. And you know, we looked at other things, like for example, the biomechanical load and how you handle the patient once the patient is in the BCP. As you know, our body is not configured to handle weight above the shoulder level because of our, you know, how our shoulders are configured. So you try to minimize you try to minimize the handling on the top, and even less on the bottom, where you want to handle the less, the least weight, on the floor level. So all these things, we kind of looked in detail and put it into practice. Yeah, these are just more images that are going to be available, and of course, we also had. We also looked at recommendations of best practices from other colleagues from some systems within the U.S. that that were very costly. They cost a lot of money, but they're best practices. I mean, they work really well. And for example, scissor lifts, more spacious BCPs, not having shelves on both sides, but only in one side, so you can have more space to handle inside the BCP. But that also meant that you need to have more BCPs. So it's a trade-off. So in conclusions, we basically worked on the principles of participatory ergonomics, where we gave word and power on what the workers were doing and how are they doing their best practices, and we put it into perspective with the evidence-based science that's out there and the literature, and also the expertise of the group. We're suggesting best practices and including the safety seating handling in emergency planning, especially in BCP designs, which is also very important. Vendors that used to provide these body collection points usually don't have a lot of expertise in occupational health and MSD prevention. So having these guidelines would also help industry to design and manufacture BCPs that would actually be helpful and not have something that you need to redesign and once you purchase it or once you place it in the health system. There are tons of guidelines out there, but none of them have the seating handling considerations as a whole. And I just want to acknowledge the group of people that worked on this, which was an amazing 2 years. We met every 3 months for 2 years and a half, and then we had subgroups that were meeting monthly, doing different specific topics between everybody's expertise. So I just want to acknowledge all my colleagues, but specifically acknowledge all the workers that helped on this project. They were actually the engine of all this, physically, mentally, and spiritually. We lost a lot of co-workers, and so a lot of acknowledging all the engineers, transporters, even security workers that they were pushing patients because there was just not a lot of people. But we hope that that this contribution just opens up a door for to think about this and acknowledge all those workers that were going out there to work when they were telling us to stay home. The world was continuing to function, and these are essential workers and basically the most vulnerable when it comes to the health system. You don't have to treat a live patient to be a health worker. You can actually be the person who cleans or the security person in the door. You're still a health worker because you're within a health system. So that's something to think about. Some references. I can share these slides. And before I go, I want to invite you to our ICO Occupational Health for Health Workers conference in New York City in October. If you have the chance to go or register online, you're more than welcome. BGW is one of our supporters, and in fact, Miriam is going to be there, and some of our colleagues. So appreciate your attendance, and thank you very much.
Thank you so much, Acran. I think we all remember the pictures of the trucks that had to be hired, especially in the States or in Italy, because the morgues were full and people didn't really know what to do. But I don't think we often think of the people who actually have to handle them and have to deal with this. So thank you so much. Maybe just a very quick question if there is one from the audience before we move on, so we still have enough time. If not, we can also have a look at the end. Or maybe is there a brief question online which maybe suit Acran?
Yeah, just a quick question. Are there any initiatives to implement those guidelines in other countries that were highly affected from COVID?
So the best practice guideline is not published yet, but we as a group are in different podiums around the world, like I am here, talking about this just to create awareness and also give the resources for other colleagues in other parts of the world to also have this initiative. But we've been asked to also counsel and help other countries that would want to have this initiative, and we're more, any of us can do this. We're more than welcome to also share experiences and hands-on, of course.
Okay, yeah. Thank you so much. Okay, then we're going to move on, have our last contribution for the day, and I want to welcome Yvonne Straub. Thank you so much for being here. She has joined us from Switzerland and has originally studied physiotherapy, but after a few years in the profession wanted to get more into the prevention side of things and did a master's degrees in ergonomics in England as well, so brings a lot of international perspectives. And she has been involved with the SUVA, which is the Swiss Social Accident Insurance Institution, so kind of the equivalent to the BGW. And they are actually also a member of our ESA section, so we're very happy to have her here today. She brings a lot of expertise, especially about ergonomic aspects in occupational health, and she will give us an insight into that work today. Welcome.
Grüezi miteinander. Ich werde auf Deutsch wechseln.
Grüezi, as they say in Switzerland. I'm going to switch to German, and I hope that you will be able to deal with my accent, even without translation to normal German. It is a great honor to come to our big neighbor and to present what we have done over the last few years in order to prevent musculoskeletal diseases, in particular among healthcare workers. We launched this before COVID as a project, the clever transfer of people who need support. So this was a pilot, and for 2 years, 1.5 years, we are in the different institutions, and we're trying to advertise this, champion this. This is not a new method, it's a principle that builds up on existing principles in cooperation with many organizations that you can see shown at the bottom of this slide, associations and organizations in Switzerland who are active in the health sector. Why SUVA? Well, as you heard, we have similar tasks than the BGW. On the one hand, we are the accident insurance, but we are also responsible for prevention of occupational diseases. My team, ergonomics, occupational diseases of the musculoskeletal system. And we base our work on the requirements that exist for companies. There are legislations and directives that allow us to tell organizations that they need to do something in order to ensure the protection of their staff's health. And we can enforce that. It's very important for us that companies comply with that, and they need to be aware that they are legally obliged to do this. When we go and visit companies and audit them, we mostly assess the physical load of health workers, and we sit down together with the organization and look at the evaluation and define measures. And we also have the task of providing skills to the companies. It's not enough to say, okay, you have a certain requirement to not exceed a certain load, and you need to make a hazard analysis. We also need to show organizations what they can do in order to minimize and mitigate risks. And I'm going to talk about this today. I'm going to let you know how we try to support organizations in this, because in Switzerland as well, we're facing huge challenges and issues. We've been hearing about them yesterday already and today as well. So we are not alone with this. You are not alone with this. We have many days lost, many people who suffer from diseases, and they need to quit their jobs even shortly after their qualification or at a later stage. So really, healthcare workers have the same workload as those who are working in construction, for instance. They also have 12 to 3 lost days. 12 to 13, sorry. And in Switzerland, we have much higher costs. In Germany, it's 200 to 300 euros per person a day. In Switzerland, we count 1,000 Swiss francs, but that includes also indirect costs. So even the bunch of flowers that might be sent home, but it's a lot of money that is involved, and that could be saved. So we have called it the clever transfer. This is a principle, as I said, that builds up on existing principles. On the one hand, we have prevention-oriented working. For instance, how do I position my back? How do I move? How do I shift my weight? Do I wear the right shoes? And on the other hand, resource-oriented ways of working. I heard a lot today and yesterday, kinesthetics. There are many different things, ways of working. In Switzerland, kinesthetics is very well known. But all these elements need to be combined with the use of aids. So in Switzerland, that is not so well known. Kinesthetics are known, aids are not so well known. And now we are putting a focus on that in our communication. We try to raise awareness for these aids and tools. I'm going to show you a short video on that. A video on how we try to explain what the clever transfer is in hospitals and what the benefits are if the clever transfer is implemented in a hospital. I hope that this works.
Nochmal.
In der Pflege und Betreuung sind Beschwerden am Bewegungsapparat ein großes Problem. Sie verursachen hohe Kosten, menschliches Leid, Personalausfälle und großen Know-how-Verlust. Die schwersten körperlichen Belastungen entstehen beim Transfer von Menschen mit Unterstützungsbedarf. Hier setzt der clevere Transfer an.
Are experienced when handling patients that need support. The clever transfer helps to mitigate the risks for musculoskeletal diseases. It means a systematic use of aids combined with a prevention and resource-oriented way of working. The combination of these three elements mitigates the load borne during the transfer. The systematic use of aids facilitates the transfer, just like shifting up with a gliding aid can help. You spare your healthcare workers' resources. So you promote a resource-oriented way of working during transfer. Do your healthcare workers take care of not lifting, but rather shifting weight? All the resources in your organization are valuable, so spare the resources when your healthcare workers handle people who need support. So the person can shift their weight and glide towards the head of the bed, sparing the healthcare worker. If you take care of the health of your workers, this will promote a long-term positive cooperation. The clever transfer unites three elements to form a whole. So make use of this principle for your organization, for your staff, and for those people who need support. This helps you increase the quality and safety. You create attractive working environments. You avoid the loss of know-how, and you save time and resources. The principle of the clever transfer is already implemented by many partners. Together with them, SUVA will help your organization relieve physical loads. Be a professional. Protect your healthcare workers with the clever transfer. So this was just a short commercial, so to speak. But I think it shows very well that there's still a lot of potential for healthcare institutions. We have a website, suva.ch/cleverer-transfer. You can look it up. It's freely accessible. With this website, we want to provide organizations everything they need in order to implement the clever transfer. It's supposed to work like a drawer system. On the one hand, it is shown from A to Z how organizations can engage here. We have a top-down approach. So first of all, we reach out to the management, or at least those who are responsible for care, that they put it all on track, that they procure the aids and then train their staff. And as in Switzerland, it is a little difficult to source the aids. We list a number of suppliers where you can find these aids. And number 3 is an important element. There are many, many training videos that do not just explain a transfer. This is how to do it. But based on the transfer, it is explained how you can make use of aids. And you can find a lot of documents, instructions on how to provide a training, and also what to take into consideration in terms of space arrangement and work organization. We provide some tips here. The aids and also the hazard assessment. That is something that can be freely downloaded, so every organization can get prepared and have a look at the most important points and tackle the issue in this way. It's supposed to be a transfer of knowledge that can build up on the pre-existing know-how of people, so it's easy to self-teach yourselves, but there are also trainings by third-party providers, ergo coaches, for instance. You can have them trained in such training courses. When visiting organizations, we have realized that the organizations know about the issues they are facing. They know that it's a problem, but we hardly ever see systematically planned work processes. And the legal requirements are known in part. A contact person, like an ergo coach or a transfer coach, is something that you rarely find. Sometimes you have people responsible for kinesthetics. Rarely you find a trainer that have further skills in kinesthetics. There's not a lot of knowledge about aids that exist. And those are the 3 major measures that we discuss with the team. First of all, you need to find a topic owner. Somebody needs to take ownership and be the contact person so that those who need to reach out find somebody. And that even smaller aids should be planned for systematically, even in smaller transfers, and not, oh, I'll do it like this today and she's going to do it in that way tomorrow. No, you really need to put it on paper. And you need to have fresh up trainings when it comes to the ways of working and the use of even small aids. As I said, this was a pilot that we did, and the pilot organizations that have participated have given us very positive feedback. They all were asked to kind of self-learn the knowledge and then to implement it in their organization. A few had the pleasure of getting trained, so that the multipliers were trained, but we can see that the organizations really benefited from it when it came to recruiting staff. They had less absenteeism, and in particular during COVID, there were some organizations that really thought that the tubular transfer aid was very, very helpful. So this system is for hospitals, but also for nursing homes, but you can also use it when nursing at home. And another important point that I'm going to address later is that you need to involve caretakers who take care for people at home. That's very important. We are still creating documents, for instance, a leaflet for people taking care of patients at home, but also when it comes to good shoes. You see Crocs less and less, but there are still shoes with a strap at the heel, and we need to really let people know that closed, well-fitting shoes are very important. What is also something that we're putting on track is the aid suitcase. It's an aid kit, but this is something that we will pilot in 2024. We want organizations to order such a kit, and then during a promotion week, it's not about training staff members, but to just get them to know the aids, to just give them an incentive so that they feel like they want to know more about it, just to have a first idea of what the aids are. Obviously, we reach out to the organizations. We want management to be involved, and we want them to organize trainings for staffers. And furthermore, it's really very important to involve trainees, and we are now starting with 3 training centers in Switzerland, where those who are still in qualification measures get to know this tubular gliding aid, and they need to take it to their hospital where they are working in order to solve a little homework task. So we try to even get into the hospitals bottom-up, with a bottom-up approach, and have the knowledge shared with other co-workers as well. And this is right on time, a short overview of how we try to mitigate the physical stress that health care workers are bearing. Thank you. Wonderful. I will stick to German for now, and I would like to thank you for your contribution. It's, yes, almost right on time. If it's fine for you and we can add another minute, steal it from your break, so to speak, then I would be happy to accept questions that you might want to ask. Otherwise, I'm pretty sure that the speakers will be available during the break. So if you have a question, maybe approach them during the lunch break. But still, I wanted to offer the possibility to ask questions. Any question to Ms. Straub? That's not the case right now. Anything else online, maybe? Are there any questions that have been posted?
Nein, wir haben tatsächlich keine weiteren
No,
Fragen.
indeed, no. All right, great. So we're not going to let you starve. Thanks to everybody who listened. Thanks to our panelists, and we're looking forward to more fruitful discussions. Thank you very much.